Hello and welcome. I'm Fernando, a GP in the UK. Today we're going to do an up-to-date review of the NICE guideline on the management of stable COPD in adults, always focusing on what is relevant in primary care only. If you wish to know about COPD diagnosis, please see the corresponding episode on this channel. The link is in the episode description. Right, so let's jump into it. For COPD management, once we have offered smoking cessation advice and support, we will offer inhale therapy. Let's have a look at the different types of inhalers. We have short-acting beta-2 agonists or SABAs, like salbutamol, short-acting muscarinic antagonists or SAMAs, like ipratropium, inhaled corticosteroids, long-acting muscarinic antagonists or LAMAs, and long-acting beta-2 agonists or LABAs. When do we use the different types of inhalers? Well, these are the general rules to follow. We will use short-acting bronchodilators, that is either SABAs or SAMAs, as necessary to relieve breathlessness and exercise limitation. We will judge the effectiveness of bronchodilator therapy depending on symptom improvement, not just lung function alone. We will not use oral corticosteroid reversibility tests to identify who should be prescribed inhaled corticosteroids, because oral steroids do not predict response to inhaled corticosteroid therapy. We will take into account the risk of side effects, including pneumonia, of inhaled corticosteroids in COPD. Inhaled combination therapy refers to combinations of a LAMA, a LABA, and inhaled corticosteroids, and combination therapy is recommended in confirmed COPD with shortness of breath or exacerbations despite short-acting bronchodilators. Let's now look at the different combinations and when to recommend them. We will offer a LAMA-LABA combination if there are no asthmatic features or features suggesting steroid responsiveness. This includes a previous diagnosis of asthma or of atopy, a higher blood eosinophil count, substantial variation of at least 400 milliliters in FEV1 over time, or substantial diurnal variation of at least 20% in peak flow rates. On the other hand, we will consider a LABA inhaled corticosteroid combination if these asthmatic features or features suggesting steroid responsiveness are present. And let's stop for a moment to remark that the LAMA inhaled corticosteroid dual combination does not appear as a recommended option. Now, what can be recommended after dual combination therapy is triple combination therapy with a LAMA, LABA, and inhaled corticosteroid. Triple therapy is recommended if they have a severe exacerbation, that is, an exacerbation requiring hospitalization, or they have two moderate exacerbations, that is, exacerbations requiring oral steroids and or antibiotics within a year, or if they have significant symptoms. However, for those patients on a LAMA-LABA combination, that is, patients without asthmatic features or features suggestive of steroid responsiveness, we will first give a trial of a LAMA-LABA inhaled corticosteroid for 3 months only, and then review. If symptoms have not improved, we will revert to the LAMA-LABA combination, but if symptoms have improved, we will continue with a LAMA-LABA inhaled corticosteroid triple therapy combination. NICE has produced a one-page visual summary covering non-pharmacological management and use of inhaled therapies in COPD, which I will review at the end of this episode. Now let's focus on inhaled therapy a bit more. What delivery systems can be used to deliver inhaled therapy? Although alternatives can be offered if necessary, in most cases a handheld inhaler, including a spacer if appropriate, is best. In that case, we will give advice on spacer cleaning, telling them not to clean the spacer more than monthly, washing it with warm water and washing up liquid, and allowing it to air dry. This is to avoid build-up of static, which can affect its performance. We will consider nebulizer therapy if there are significant symptoms despite maximal inhaler therapy, and we will continue only if there is symptomatic improvement. And we will offer a choice between a face mask and a mouthpiece unless the drug specifically requires a mouthpiece, for example, anticholinergic drugs. What oral therapy can be given in COPD? Well, long-term use of oral corticosteroid therapy in COPD is not normally recommended. Some people with advanced COPD may need long-term oral steroids if it cannot be stopped following an exacerbation. In these cases, the dose should be kept as low as possible. We will monitor people on long-term oral steroid therapy and give them osteoporosis prophylaxis if appropriate. However, we will start osteoporosis prophylaxis without the need for monitoring in patients over the age of 65. We will consider mucolytic drug therapy for people with a chronic cough productive of sputum. Oral antioxidants and oral antitussive therapy are not recommended. Before starting prophylactic antibiotics, we should seek specialist input. Azithromycin, usually 250 mg 3 times a week, can be given if certain conditions are met. Because we will normally be guided by secondary care, I will not go through all these conditions and precautions here. For people who are taking prophylactic azithromycin and are still at risk of exacerbations, we can provide a non-macrolide antibiotic to keep at home as part of their exacerbation action plan, explaining that it is not necessary to stop prophylactic azithromycin during an acute exacerbation. In this episode, I will not cover the management of pulmonary hypertension and copulmonale, and the use of oral phosphodiesterase 4 inhibitors, non-invasive ventilation, oxygen therapy, either long-term, ambulatory, or as short bursts, and oral theophylline, except for saying that we should reduce the dose when prescribing drugs that interact with it, such as macrolide or fluoroquinolone antibiotics. In terms of self-management, we will develop an individualized self-management plan, including an exacerbation action plan if the patient is at risk of exacerbations. For this, we will offer them a short course of oral steroids and antibiotics to keep at home as part of their exacerbation action plan. We will do this if they have had an exacerbation within the last year and remain at risk of exacerbations. They understand when and how to take them, and they inform the healthcare professional when they have used them and ask for replacements. There is separate guidance on the choice of antibiotics for acute COPD exacerbations. I will cover these recommendations in my next video on COPD exacerbation management. For people who have used 3 or more courses of oral corticosteroids and or oral antibiotics in the last year, we will investigate the possible reasons for this. We will offer pulmonary rehabilitation to those functionally disabled by COPD, usually with an MRC dyspnea grade 3 or above. Pulmonary rehabilitation is not suitable for people who are unable to walk, who have unstable angina, or who have had a recent MI. We will offer pneumococcal vaccination and an annual flu vaccination to all people with COPD. There is separate guidance on the use of antivirals to prevent and treat flu, which I will not cover here. I have put a link to it in the episode description. We should consider physiotherapy for people who have excessive sputum so that they can be taught how to use positive expiratory pressure devices and active cycle of breathing techniques. We will monitor for the development of anxiety and depression and their nutritional state and BMI. Whilst the NICE guideline on obesity states that a healthy BMI is between 18.5 and 24.9, this may not be appropriate for people with COPD, where it is recommended a BMI between 20 and 25. With that in mind, we will refer for dietetic advice if they have an abnormal BMI, and for people with a low BMI, we will give nutritional supplements and encourage them to exercise. We will regularly ask people with COPD about their ability to undertake daily activities and assess their need for occupational therapy. We will also consider referring people for assessment by social services if they have disabilities caused by COPD. When appropriate, palliative care for end-stage COPD may include the following treatments for breathlessness that is unresponsive to other therapies: opioids, benzodiazepines, tricyclic antidepressants, major tranquilizers, and oxygen. During follow-up, we should include smoking cessation, record spirometric parameters, and a loss of 500 mL or more over 5 years in FEV1 suggests rapidly progressing disease, which may need specialist referral and investigation. During the clinical review, we will cover the following issues. In mild, moderate, and severe COPD, that is stages 1 to 3, we will review them at least annually. We will assess smoking status, symptoms including breathlessness, exercise tolerance, and exacerbation frequency, need for pulmonary rehabilitation, presence of complications, and medication, including inhaler technique. We will measure FEV1, FVC, BMI, and MRC dyspnea score. In very severe COPD, that is stage 4, in addition to this, we will review them at least twice a year. We will assess the presence of cor pulmonale, the need for long-term oxygen therapy, the nutritional state, the presence of depression, the need for referral to social services, occupational therapy, and for specialist input. As I mentioned earlier, NICE has produced a one-page visual summary covering non-pharmacological management and use of inhaled therapies. Let's have a look at that. Now, so once we have confirmed the diagnosis of COPD, we will cover the fundamentals of COPD care. That is, we will offer treatment and support to stop smoking, pneumococcal and influenza vaccinations, pulmonary rehabilitation if appropriate, develop a personalized self-management plan, and we will also optimize treatment for comorbidities. And we will revisit these plans at every review. Then we will start inhaled therapies only if after doing all this, they are needed to relieve breathlessness and exercise limitation, as long as they can demonstrate satisfactory inhaler technique. And we will review the medication and assess inhaler technique and adherence regularly. So we will offer a SABA or a summer inhaler to use on demand. And if the patient still has symptoms or has exacerbations despite treatment, we will see if there are asthmatic features or features of steroid responsiveness. And let's remember that these features in this context include any previous secure diagnosis of asthma or atopy, a higher blood eosinophil count, a substantial variation in FEV1 over time, that is at least 400 milliliters, or a substantial diurnal variation in peak flow of at least 20%. So, if these features are not present, we will offer the combination of a LAMA and a LABA. And if despite this, the patient's symptoms are not adequately controlled, we will consider a 3-month trial of triple therapy with a LAMA, a LABA, and an inhaled corticosteroid. Bearing in mind the increased risk of side effects of inhaled corticosteroids, including pneumonia, and we will document in the clinical records the reason for continuing the inhaled corticosteroid treatment. But if there's no improvement, we will revert to dual therapy with a LAMA-LABA combination. If the issue with the LAMA-LABA combination is that the patient has 1 severe or 2 moderate exacerbations within a year, then we will also consider triple therapy with a LAMA, a LABA, and an inhaled corticosteroid. This is because inhaled corticosteroids have been proven to help reduce exacerbations. On the other hand, if a patient on a SABA or a SAMA has asthmatic features or features suggesting steroid responsiveness, then we will offer treatment with a combination of a LABA and an inhaled corticosteroid. And if a patient continues to have significant symptoms or has 1 severe or 2 moderate exacerbations within a year, then we will offer triple therapy with a LAMA, LABA, and an inhaled corticosteroid. And for all these patients, if symptoms or exacerbations continue to be a problem, we will explore further treatment options, including referral. We have come to the end of this episode. Remember that this is not medical advice and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching and goodbye.